Tekrar hoş geldiniz.
Welcome once again. I will be speaking about the neurobiology of the sleep in the anxiety disorders. Of course, sleep is such a mysterious thing, and it is such a complex thing, especially when it comes into play in the anxiety disorders, and there are some overlapping points that I will try to summarize in my speech. Anxiety disorders, along with the other psychiatric disorders, are one of the leading causes of the disability in the world. According to the World Health Organization, 1 out of 3 people indeed suffers from a pathological anxiety episode at some point in their life. Rates of anxiety disorder in Turkey and many countries are reported to be up to 25% in both adult and child samples. According to the rating system, this is the rating of the anxiety disorders. Let us briefly speak about the neurobiology of anxiety. This is the first model that comes into play in the 1937. A stimulant is going through cortex to thalamus and then hippocampus to the mammillary body. After they are processed there, they go back to the thalamus, and as a result of that, the response is emerged. This model To this model, the attachment of the septum and the amygdaloid complex to the structure of the limbic system was important. In case of a real or false threat, amygdala activity influences many brain regions with different projections. Fight, flight, or freeze reactions will be emerging. In 1958, according to the attachment of the nauta, the definition of the periaqueductal gray matter, locus ceruleus, dorsal raphe nucleus, ventral tegmental area, and the reticular formation will be also added to the neurobiology of the anxiety. And for the first time, monoamines have contributed to this system, and for the first time, their functions have been added to the neurobiology of the anxiety. When we are speaking about the anxiety, of course, the flight, fight, and freeze reactions are resulting from the stress response system. As you all know, hypothalamus, hypopituitary, and the adrenal axis is quite important. Especially in the cases of waiting anxiety, this system comes into play. What happens? The stimulants are coming, and as a result of that, ASTA is being released, and the cortisol is also released, and the cortisol retrospectively gives a feedback to hypothalamus. As the cortisol increases, what happens in the CNS? The mood changes, there is a decrease in the threshold of the episode, and many sleep disorders emerge. And in addition to that, corticotropin releasing hormone, after it is being released, limbic system and the locus ceruleus is being stimulated, and it results in the anxiety. Let me briefly speak about the cholecystokinin system. Increase in CCKB release in the frontal cortex and the limbic system in the case of anxiety is a reality, and the CCKB antagonists are anxiolytic in animal models. And I don't want to go into the details of those, as it was already mentioned by the previous speakers. Monoamines are indeed the molecules which are also contributing to the anxiety. When we are speaking about the stress and arousal, we see that the awake response to stress consists of 3 components: hormonal, behavioral, and autonomic. The hormonal component, as I mentioned, is directly correlated with the CRH system, and the behavioral components are directly correlated with the LC and autonomic NS system. Here, the norepinephrine, the increase in the norepinephrine inhibits the parasympathetic system and the vegetative functions. As a result of that, it inhibits the sleep. And at the same time, the NE also increases the release of the CRH, allowing the continuation of the wakefulness even if the stress goes up. If this cycle is becoming chronic, then the depression and the anxiety disorders might be easily developed. That's what has been taught in the literature. So what is the relation of those components? The REM sleep is induced by the increase of NE release from locus ceruleus. The chronic stress causes REM sleep to decrease, while slow wave sleep increases. And of course, I will indeed repeat it once again, this is just like a prototype of the anxiety disorders. Insomnia, as I will briefly mention in the following speech, leads to some sleep disruptions, and insomnia have increased arousal during the day, and this has been proven in the electrophysiological studies. There are some points in which the anxiety disorders and the sleep overlaps. Approximately half of the sleep problems in the adults are associated with the anxiety. Although this relationship is also very strong in the childhood, especially in the school-age children, although there hasn't been many studies. It has been reported that at least one problem related to sleep is observed in 80 to 90% of the anxious children. In the recent time, the generalized anxiety disorders has been evaluated most commonly. Of course, generalized anxiety disorders and the panic disorders are quite common, but the social phobia might lead to sleep problems as well. What happens in the generalized anxiety disorder? Prolonged sleep latency, prolonged REM, and difficulty awakening in the morning hours are among the consequences of the GAD, the generalized anxiety disorder. These four symptoms are the problems that are commonly observed with the GAD: daytime fatigue, exhaustion, difficulty in falling asleep, night wakes, nightmares, and refusing to sleep alone. And according to the panic disorders, nocturnal panic attacks might also be observed in the second phase, in the transition from second phase to the SWS. Let me open a brief parenthesis to insomnia, because insomnia is quite commonly seen in the depression and the anxiety disorders. In order to have a healthy sleep, the insomnia creates a problem. And the most common problem is insomnia by 70 to 90% in the anxiety disorders. One publication really attracted my attention, and this study has been published in 2009. And here, two different dimensions of the bidirectional model of anxiety-insomnia relationship has been mentioned. And the author said they are the two different dimensions of single neurological diathesis, or they are two separate disorders that are overlapping symptoms of, or they are affected by a third factor. In the following studies, the first hypothesis has been supported. The author continues. The overlapping of the PFK and the limbic system dysregulations are another factor that we should take into consideration. The PFK is responsible for alertness, arousal, and executive functions. Sleep impairments impair the regulatory influence of the PFK by weakening the connections between the PFK and the limbic system, which increases sleep problems through alertness and arousal functions. Let me go back to the monoamines. I will try to summarize them. As Mr. Şahin mentioned in his speech, the inhibitor neurotransmitter released from the neurons in the basal forebrain is quite important. GABA is an important inhibitor, and it creates an anxiolytic effect. The increase in GABA causes anxiety reduction in animal models due to the projections extending from the basal forebrain to amygdala. Decrease in the GABA transmission is associated with a decreased seizure threshold and anxiety. Of course, we always focus on GABA-A receptor, and the benzodiazepines have been used quite extensively in the clinic. The GABA-A receptors, the benzodiazepines, work as an anxiolytic and hypnotic by their GABA agonistic actions. And we are really concerned when we are prescribing the benzodiazepines, because they might have some adverse effects. And that's why we are using BDZ-like agents. In Turkey, Zopiklon is used in Turkey, but as far as I know, it is not preferred for the age group below 18, or it is not reimbursed in Turkey. Although I didn't write it in here, I would like to speak about pregabalin. I'm sure you have encountered with the demand coming from the pregabalin. I'm sure you have seen some forensic cases, or you might see some problems with the family of the patients. Pregabalin is actually used for neuropathic pain. It's a GABAergic agent, but it also has hypnotic and anxiolytic effects. But it has some abuse characteristics if it is used in the higher dosages. That's what I would like to say. I have already spoken about the norepinephrine. We know that the noradrenergic neurons in locus coeruleus are associated with the attention and arousal. Activation during stress is observed in the norepinephrine neurons and ventral medulla. Increase in the norepinephrine tone in anxiety is thought to be one of the conditions leading to insomnia, and it also has an impact on the hippocampus memory storage. Because especially after the panic disorder and the post-traumatic stress disorders, it might have an effect on the mechanisms for the conditioned concern. And pilosocin, which is an alpha-1 receptor, might be inhibited in order to reduce the nightmares. Histamine doesn't have a clear-cut mechanism on the anxiety, but we know that it is working on the H1 receptor. Diphenhydramine, prilamine, and doxepin cause an increase in the non-REM and the REM sleep. And it creates a huge impact for us in the anxiety disorders. Serotonin matters. It has an anxiogenic effect, but serotonin has different impacts in different parts of the brain. And the preoptic area, basal forebrain, and the hypothalamus and the thalamus is being inhibited, and it has a huge impact on the whole sleep mechanism. Serotonin increases the wakefulness, but at the same time it reduces the REM. As a result of that, the SSRI, the selective serotonin reuptake inhibitors, might have the similar impact. As I have already told you, there might be different activities for monoamines on different parts of the brain. The HT1A receptors and the HT2C receptors are focused, and they are the major inhibitors. And these receptors might have correlations with the GABAergic system as well. The 2C receptors, according to the animal models, demonstrate that the knockout animal models demonstrate decrease in anxiogenic responses and decrease in the CRH neuronal activity in the amygdala. So these two receptors have indeed the opposite mechanisms. Of course, there is no need for going into the further details, but these are the drugs that we commonly use for the anxiety disorders. The SSRI is indeed creating a prolonged REM latency. The TSA has the same effect, and in addition to that, it reduces the REM duration and deep sleep latency. And non-tricyclic indeed monoamines are having the same effect, and mitrazepine is the most commonly used drugs. These are the less commonly used agents, and trazodone might be added to this presentation, but we don't have a clear-cut answer for their action of mechanism of action. Melatonin might also have an impact on the anxiety. We know that it is released from the N-acetylserotonin. It has a huge impact on the circadian rhythm as well, because circadian rhythm has an important effect for the mood stabilization, appetite. The melatonin has such an important impact on the aforesaid issues. M1 and M2 receptors are important. In the last decade, the M2 receptors have a higher impact with comparison to the M1 receptors in the anxiety. Both melatonin itself and the non-selective agonists, when they are delivered to the animal models, the anxiolytic effects have been observed. Increase in melatonin in the limbic system leads to increased GABAergic activity in the hypothalamus, cortex, and cerebellum. It has such an indirect effect. Maybe this is something new. This molecule, I have encountered with it quite commonly, but it is not in the clinical phase right now. And this is the partial agonist of M2, UCM765. It has anxiolytic effect in low dosages and hypnotic effect in the high dosages. If the clinical phases are completed, maybe it might be much commonly used because it has less sedation compared to benzodiazepines, and it might have a lower abuse risk. As the previous speaker has already mentioned, orexin is another important system. I will try to be as short as possible. What is the relationship of orexin on the anxiety? We know that orexin is responsible for the wakefulness. As there is a reduction in the GABAergic tonus, then the risk will be increasing, and it will increase the arousal and the panic symptoms. In the animal models, when orexin antagonists are delivered, the anxiety behaviors have been reduced and the sedation has been realized. This was a scheme this was a chart that we have already seen. You see which parts are innerved. It has such a key role in the sleep mechanism. I would like to speak about the Adolescent molecule. It is a receptor antagonist of orexin. During the phase 1 and phase 3 trials, since it has a huge side effect profile, the study was cut in 2011 and it was recalled from the market. In order to use my time efficiently, I would like to finish with my conclusion. Last but not least, anxiety disorders affect a large part of the population. There is a close link between anxiety and sleep-related problems. And it is important that these mechanisms are known before environmental regulations and treatment options for sleep-related problems are implemented. And for the future, the development of anxiety disorders in childhood and development of sleep-relatedness and treatment modalities for this age group have not been adequately investigated, and maybe it might be a hint for the future studies. Thank you very much for your patience.